Very good evening to all of you. I hope I'm audible and visible to all the students on YouTube. Happy Basant Panchami and Saraswati Puja to all the people listening to me. Right? Very good evening to all of you. Sure. But people who are married, like me, or maybe couples, I was today stuck between two different things. One is Valentine's Day and the other one is the Saraswati Puja. Maybe you might buy this flower, I might buy that flower. Then we are not the same, bro. Maybe sometimes married people like me don't believe in this Valentine's. Right? Okay. Sure. Now, let's move into a topic that you are somewhere scared of reading every time, especially in the ward. When you see people with a patient or a patient with aphasia there. So I will try to make it as simple as possible. A crisp and a quick topic of aphasia. Right. Chalo, let's start. Let's begin. To understand aphasia, we need to go into the very basic concept of the circuit of speech. Now, whenever you hear something and you see something, you try to assimilate the same thing in the brain in the Wernicke's area. That is an area for comprehension that we know. Then we have an area for the speech output or the word formation, that's the Broca's area. Wernicke's is like on the receiving end. It's a kind of a sensory thing that it senses something that you see and you hear. While Broca's is going to make the word there. So it needs to be connected with the motor area. Now these two motor areas connected with the Wernicke's and Broca's are the association areas, right? Okay. Now connecting Wernicke's and Broca's, there has to be other kind of fibers. So let me locate them. Where are they actually located in? The auditory area is located in the temporal lobe. The visual cortex, we all know, is in the occipital lobe. The Wernicke's area is in the temporal. The Broca's area is in the frontal. Now to connect with this Wernicke's and Broca's, we have got two more areas which are known as sensory and the motor association areas. And then finally from here, the speech output will come out. Right? Now to connect the temporal with the frontal, the Wernicke's with the Broca's, we have a simple zone of fibers passing between the two known as the arcuate fibers. The arcuate fibers. So any deficit lying on the way in the speech circuit, we are going to have a problem known as aphasia. Now I'm going to pull out this topic into a very simple format of a triad. Now the first variable that we understand aphasia through is a comprehension, ability to understand something. For example, if I give you this command to see and tell me, select all the images which contain stairs within it. So you're going to see this one, and this one. Maybe these two poles can be a stair for climbing somewhere else, but it's not a stair. Rest all you can see are the trees and the road. So you see, you understand, and you try to understand it in a way that you're able to mark it properly. Now, for comprehension, please remember, we always have got an area to understand something. That is the Wernicke's area. Now for comprehension, although I've given you an example through vision, but most of the time the comprehension happens through the auditory area. That means if I give you a command to raise your left hand, you'll listen to me, you'll understand, and you'll perform the task. But you'll only raise your left hand, not the right one. So there's another area known as sensory speech association area that would be connected with it. Okay, so there will be a sensory speech association area that will be connected to it to make you understand the command properly. Then we have another area for repetition. Now please remember, in this whole drama of comprehension, We don't require the Broca's area at all, neither the motor speech association area for that. Okay, so these are the three areas required for understanding or comprehension. Now, the second would be repetition. Like this, what is written over here in a CAPTCHA? Don't type. But you'll still type it, no? You'll understand on seeing, although it's written don't type, doesn't mean don't type literally. I have to type the CAPTCHA. The computer wants to know I'm a human being, right? Now for repetition, for example, I'll give you a simple thing to repeat with me, 1 plus 1. If you understand it, you'll make it as 2, but you don't want to understand it. You just want to repeat the word 1 plus 1. So please remember, for repetition again, the input comes through the auditory route, 1. And for repetition, you require the Wernicke's area and the Broca's area with an intact fibers between the two known as the arcuate fibers. So please remember, for repetition, you don't have any association area involved in it. Because if you want to understand the word 1 plus 1, you'll understand it deeply, right? Like 1 plus 1 is 2, but you don't want to understand that equation. You want to just repeat the same equation, right? Then comes the naming part. This might sound silly to some of the people, but I'm very well aware you know this gentleman. Recently, he came in a popular ad with a star of Bollywood recently. Yeah. So if I ask you to name the actor, you will see his name Johnny, and then you will see a liver, Johnny Liver. Same goes with Johnny Liver, because standing with him is Ori, who is also a liver, right? So look at this now, naming again. For naming, you will try to see something, visualize it. You'll try to understand that thing in the Wernicke's area. Like Johnny Sin you saw just now, you know him in various occupations sometimes, but you're very careful in naming him, right? You name it as Johnny Liver, right? Even this is Johnny Liver because Ori is also a liver. So you understand that thing properly. That is the sensory speech association area, right? And then you make a word, Broca's, and you don't make a word like Johnny Uri or Johnny Sin. You make a word like Johnny Liver. So you derive a right word from your motor speech association area. So like sensory speech association area helps you to understand the command better. The motor speech association area will help you to make a correct word out of the two. And then finally the arcuate fibers are coming out from this part to this part. Right. So we have the entire network of the entire speech circuit being arranged over here, right? In naming, right? Be careful. Okay. So Johnny Sin had a crossover into Bollywood, that too into the TV serial. I was really amazed. It was a serial like Sasural Simar Ka. It looked like Sasural Sin Ka, right? Anyway, the last one is the fluency. Not deviating from the topic. The last word is fluency. You make a word when you make a proper word every time. That means for fluency, you require a Broca's area. Okay. And you will always require a motor speech association area to make a right word. Just for a clinical reference, Chatur Ramalingam from Three Idiots, he went down to the stage on the Teachers' Day and started speaking on his own. He never understood what the crowd is laughing about. He thought all the time that they are cheering him up, and he was so fluent in his speech. Koi seekhe to inse seekhe, right? So Broca's and the motor speech association area are helping me to form the word. I don't understand sometime what I'm speaking. So for fluency, you require these two things, right? A spontaneous speech. So let me remind this all again. For comprehension, I require an auditory area. Wernicke's area, and the sensory speech association area, right? For fluency, I require the Broca's area and the motor speech association area. For naming, I will require the visual area, Wernicke's, sensory speech, arcuate fibers, Broca's, and almost everyone on the way. And for repetition, I don't require any kind of association area. The input comes to auditory, Wernicke's, arcuate fibers into the Broca's area, right? Okay. Chalo, let's start with the first aphasia, Wernicke's aphasia. If you have a damage in the Wernicke's aphasia, this wala part. One thing is very clear, your comprehension is lost, your naming is lost, and your repetition is perfectly alright. But as far as Wernicke's area is concerned, it never went for fluency. So your fluency can be normal and might be increased also. Like sometimes the patient won't understand what he is speaking. He will come out like Rancho in the class and write 2 words, pre-radicalization Farhan nitrate. These 2 words carried absolutely no meaning with them. So this was symptom seen very well in them when they don't understand what they are speaking. They make out words which carry no meaning, known as neologism. As far as the fluency is increased, remember, it's a kind of a speech which is overfluent, known as explosive speech or a jargon speech, right? Explosive or a jargon speech, right? Now, what do you mean by this? Like Wernicke's area, remember, always inhibits the Broca's area. If the inhibition is gone, the Broca's will just work on its own in a way explosive or a jargon speech. If you remember the mutual fund ads earlier, they used to play a disclaimer at the last of the ad, What was the disclaimer like? A mutual fund is a subject to market risk. Please read the offered document carefully before investing. No. It never went like this. They always spoke like this, mutual fund. So it was typical an explosive or a jargon speech. Broca's aphasia, right? In Broca's aphasia, the lesion is in the Broca's area. Now in the Broca's area, we are having something related to fluency. So fluency is decreased. Naming is also done to the Broca's area, that is lost. Repetition is also lost. While the comprehension of the patient is well intact. Look at this patient now. In a patient with Broca's, he understands that he cannot speak. That's the reason he has got an intact insight into his disease. And that's why he lands up very often into a phase of depression. Right. And as far as the speech is concerned, it's often broken, like a signal of a telegram. That kind of a broken speech is known as telegraphic speech. Like the old dialogue of Shah Rukh Khan, Kiran. It's like a telegraphic broken speech. Please remember in them, their ability to sing is intact. Their melody, ability to sing is perfectly normal and intact. So that means they're speaking, they are stammering to some extent. But when they come out to sing, they become perfectly normal. That's why they've got a speech pattern that is known as melodic speech. Take out some time and watch this movie Jaga Jasoos. It's a nice movie showing Ranveer Singh having this problem. Whenever he's speaking, he's stammering. But whenever he's trying to express himself, he's able to sing properly and express himself better. And this is a part of therapy that we often use to treat these patients of Broca's, known as the melodic intonation therapy. This intonation therapy is particularly very helpful in people with non-fluent or Broca's aphasia. So what happens, in a melodic intonation therapy, a speech therapist is assigned to the patient and he encourages the patient to sing short phrases and sentence using a melodic or a rhythmic pattern. Like if I ask my patient, tell me your name, he'll understand that. But as far as naming word formation, that's totally gone. So I'll ask him, what is your name? He will like to sing it out like this. My name is. So it might sound familiar to him, this kind of a tune. He's adjusted to word output through the process of singing. Then we use the hand gesture and tapping to emphasize the rhythmic structure of the word. Like, my name is, like this. So he's now being adjusted to the gestures. And then the gradual transition into a normal speech happens. So I tell him to sing, then I tell him to use the gesture to express himself, and then it comes into his normal speech output like this. Watch this movie Jaga Jasus, you'll understand completely what I'm talking about, melodic intonation therapy. A commonly done thing in the wards, like we tell our patient to sing the chant like Om Bhur Bhavaswa. That's the Gayatri Mantra. Many of the people know it very well. And suddenly the patient starts singing it. Because that kind of a rhythm or the singing pattern is still in his brain. And maybe that was being exploited by various Bollywood directors, You might have seen some movies in the Eastman color that a person was totally mute. He went to some ashram and suddenly he started singing and his voice came back. Arey Baba, this is not a chamatkar. It is a melodic speech in which the person sings out very, very well. But as far as speaking concerned, he's totally stammering or having a decreased fluency or a telegraphic speech. Then we have the conduction aphasia, in which the damage lies over here, between the Wernicke's and the Broca's arcuate fibers. So my comprehension is intact, my fluency is intact, but my naming and repetition is totally gone. Sometimes my examiner asks me in the Viva, yes, what topics have you read? My answer is, I don't know, sir. I don't know. Okay. Tell me definition of this and this. I don't know, sir. He's asking me something and I'm uttering him something else. So there is a total loss, like Bhupendra Jogi during the Viva. Aapka naam Bhupendra Jogi. Kahan America mein gaye Bhupendra Jogi. So he's not able to connect his Broca's with the Wernicke's area. He's being asked a question and he utters out something else. Okay, conduction aphasia. Perfect. Then we have the anomic aphasia, in which the patient has got a difficult problem in naming. Naming is gone. Comprehension is intact. Repetition is intact. Fluency is normal. What is this now? Anomic aphasia. Sometimes, the patient has got not anomia, has got paraphasia, in which he is able to name something incorrectly or gives me an incorrect word out of it. There can be two types, semantic and phonemic. For semantic, I'll give you an example. I'll show my patient a pencil. He will look at it and tell me it's a pen. That's the problem. He's totally confused between two objects which are required for writing on a piece of paper, serve the same function, but they are exactly different. While in phonemic, what happens is when I show him a pencil, he will look at it and tell me it's a pentel. So phonetically is incorrect. In pronunciation is gone wrong over there. That's the phonemic paraphasia. Right? So paraphasia is just another thing in which my patient gives me an incorrect name for a particular thing. And then finally patient goes into a phase of circumlocution. I found this interesting cartoon on the net describing circumlocution. Like someone went to the mayor's office and it was locked. He's out for lunch. He read everything and at the end he read that he's out for lunch. So circumlocution refers to the use of many words to express an idea, which is conveyed, which could be converted to a simple fewer words and more directly. Like it's like beating around the bush. And this is one ability that you have inherently with you while writing an answer in the theory exam. And especially answering in Viva, the Bhupendra Jogi, circumlocution. Right? Now, please remember, anomic aphasia, whenever you see, the lesion somewhere lies in this part of the brain. The angular gyrus. The angular gyrus. Right? Now finally we have with us another aphasia, which are known as transcortical aphasia. The first one is the transcortical sensory aphasia, in which the damage lies somewhere over here in the sensory speech association area. So that is required for comprehension. That's required for naming. That may not be required for fluency and repetition. So look at this now. In my patient this time, his or her repetition is intact, fluency remains perfectly normal, while comprehension and naming is gone. So it behaves like a Wernicke's aphasia if you reflect it again with an intact present repetition. Then we have a transcortical motor aphasia, in which the damage lies in the motor speech association area. Correct? Over here. If you have a damage over here, I believe the fluency is gone. Okay. The comprehension is intact. The repetition is normal, while the naming is lost. So it's behaving more or less like Broca's aphasia with a preserved repetition. And then finally we have the mixed transcortical aphasia, in which the damage somewhere lies between this part. The mixed transcortical, the damage lies over here. The connection of these association areas with their respective parent Wernicke's and Broca's areas. So now this time in my patient, the comprehension, fluency, naming, everything is lost, and one thing remains perfectly intact. What is that? Repetition. That old Spider-Man meme I saw, No, Happy New Year, Happy New Year, Happy New Year, Happy New Year. Happy Valentine's Day, same to you, same to you. Happy Basant Panchami, Saraswati Puja, same to you, same to you. Say no worries, no worries, no worries. So this person continuously repeats the same thing. Echolalia. Echolalia is a repetitive speech pattern characterized by involuntary repetition of words and phrases. It is seen in this aphasia 1, and it is another very important symptom that we look out in children with autism and a Tourette syndrome. In autistic behavior, whatever you speak to them, they will speak it immediately, the same word back. And when they leave you later on for months, weeks, delayed also, they will keep on repeating the same thing. So echolalia is a constant repetition of the speech again and again. That is done by the patient immediately and maybe later on also. And it's very characteristic. If you see an autism kid, you'll understand it best over there. Right? And some rap artists I've seen, like Sonu Kakkad, Badshah, I don't know, whenever they write the lyrics, echolalia comes into their mind. Kaata laga uima, 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 uima. Ye ladki pagal hai, pagal hai, pagal. So they keep on having echolalia in between. Now we have an aphasia that's known as a pure word deafness, PWD. In pure word deafness, the damage lies between the auditory and the Wernicke's area. Right? So in my patient, their comprehension is lost. Repetition is lost because it requires an auditory input. While naming, I again reply, naming you don't require an auditory input. You just require a kind of a visual input. So naming and fluency is intact. I'll give you a perfect example. Like at this moment, a mobile phone starts ringing on this table or vibrating. I'll pick up my mobile phone. There's so many objects around here. I'll only pick up my mobile phone because on seeing, I know it's a mobile phone. I'll never pick up my keyboard lying over here. No. I'll only pick up my mobile phone because I look at it and I name it, it's a mobile phone. One. Secondly, whenever I listen to someone, I'll understand, but this time I don't understand. So whatever the other person is speaking to me, I'm just deaf to their words. I'm not deaf actually, I'm just deaf to words. It's pure word deafness, right? Get this very correct. And I speak to the other person also. Whatever you are speaking, I'm really not able to understand it. Okay. Then we have the pure word blindness, in which the person isn't blind actually. He's blind to words. So in this patient, I believe his comprehension is decreased only for one variable. That is reading. Rest all is well. Repetition, naming, fluency, everything is all right. So if I ask you to read these two words written over here, one in Russian, other one in Chinese, it means all the best. But can you read these words? No, you're not blind actually. You're just blind to these language words. Pure word blindness. Pure word blindness is also known as alexia. That's why Amazon, when launched the product, they named it as Alexa. Because Alexa, just like Alexia, is also blind to words. Whenever you want to communicate with Alexa, you speak it out and she replies. Okay. Then we have the global aphasia finally. And just to add on to this, pure word deafness or Alexia happens due to lesion in the splenium part of corpus callosum. Splenium part of corpus callosum. That particular zone we have a damage will lead on to Alexia. Okay. Then finally we have the global aphasia. As the name suggests, everything is gone. Naming, repetition, fluency is known as the word global. Simple. Then especially whenever the Broca's patient starts talking to you, like you ask a Broca's patient, what is your name? He'll speak to you like this. Then you'll immediately tell him, अबे जल्दी बोल, कल सुबह पनवेल निकलना है. Okay. That's a typical broken speech he's speaking with. So let's quickly revise everything in a simple way. Can the patient comprehend? No. Some problem in his Wernicke's area. Can the patient speak fluently? No. He cannot comprehend, he cannot speak. Answer me, what aphasia is this? It's a quick revision for all of you. सांग मला जो मला माहिती नाही. Tell me something which we don't know. Okay. Cannot understand, cannot speak. Simple. मर गए. Transcortical. The answer for this is total gone. What are you thinking? Global aphasia. Then finally we have this now. No. Conduction, can understand, can speak, but the connection between the two is gone. आपका नाम क्या है? भूपेंद्र जोगी. आप अमेरिका में कहाँ कहाँ गए हैं? भूपेंद्र जोगी. Look at him. He's not understanding the question. Can the patient comprehend? No. Can he speak fluently? Yes. Can he repeat? No. He can speak, but he cannot repeat, but he cannot comprehend. What are we thinking about? Yes, Wernicke's aphasia. Then, can your patient repeat with you? Yes, he can repeat. He can speak, but he cannot comprehend. That means he is a brother of Wernicke's due to the damage in the sensory speech association area. That's your transcortical sensory aphasia. Got it? He can speak, he can repeat, but he cannot comprehend. Transcortical sensory aphasia. Can the patient comprehend? Now I'll go to the next one. Can the patient comprehend? Can he speak fluently? Yes or no? Can he repeat? No. Can he repeat? Yes. Now patient can comprehend. That's the important thing here. His Wernicke's area is perfectly okay and fine. Now we're looking for his fluency of the speech. His fluency is bad. Now I'm going to look at this. Can he repeat or no? If he cannot repeat, it's a case of Broca's aphasia. But if he can repeat, it's a case of transcortical motor aphasia. The brother of Broca's with the preserved repetition. Now I'm going to look at this. He can repeat, he can comprehend, He can comprehend. He can speak fluently. Yes. Now I'm going to look at this. Can he repeat or no? He cannot repeat, but he can understand and he can speak. He cannot repeat, but he can understand and he can speak. Tell me, what aphasia is this one? Will be really happy now. Tell me this aphasia. He can understand, he can speak, but he cannot repeat. Yeah, Mogambo Khushua. The conduction aphasia. Correct. In the patient now, he can understand, he can speak, he can repeat, and only one variable is lost, that's naming. That's your anomic aphasia. Right? So that was a quick summary of everything that we have seen through. So the highlight of today's lecture maybe the chief guest was none other than the great personality that we met recently in an ad. Another crossover he had with DAMS today. Okay. So let me summarize everything again in a different way. MCQs. Okay, I'll explain transcortical aphasias again, don't worry. Answer these questions, by the way. We're going to solve MCQs finally. A lesion at angular gyrus with an intact Broca's and Wernicke's leads to what? First of all, tell me, I've written this somewhere. Angular gyrus lesion results in what kind of aphasia? Anomic. 1. But there's no option given like this, naming and all. If you remember angular gyrus from physiology, left and the right one, especially the left one is supposed to read what you have written in front of you. So any word that basically you are reading and you're understanding is by an attempt done by your left angular gyrus. So this time my patient's speech output, comprehension, repetition is not a problem. There's a difficulty in understanding the written text that's written in front of you. Him. What is this known as? I hope you know. This is known as dysgraphia. Difficulty in reading something. Dysgraphia, dyslexia, dyscalculia, disorientation to the direction, everything is a part of your famous what? The Gershwin syndrome. I hope you know it. In an aphasic patient, deficit is most commonly seen in which of the following modalities? The most common aphasia actually is always anomic aphasia. The most common aphasia is always written as anomic aphasia. Anomic aphasia, why it's so common? Because it is seen commonly in disorders which are spread on a mat. Now what is this mat? Metabolic encephalopathy, Alzheimer's disease, and head injury and trauma. 3 things. So anomic aphasia, the deficit lies in naming. So naming overall is considered to be the most commonly involved modality to be impaired in a patient with aphasia. Sometimes the book says that anomic aphasia is known as minimal dysfunction syndrome. So there is a dysfunction, but it's minimal. Why the word minimal? Because only for naming you have a problem. That's it. Right. Now, easy question, easy answer, clear answer. We discussed this concept as well. A person names plentil for pencil. I'm showing him a pencil. He names it as plentil. Is an incorrect name given to me. Paraphasia. What kind of paraphasia is it? Phonemic. Problem in phonation or pronunciation. If it would have been semantic, I would show him a pencil. He would name this as pen. Circumlocution, I'll show him a pencil and he'll keep on telling me this is an important object. We use it for writing on piece of paper, but beating round the bush, right? And echolalia, what is this? What is this? Don't you know this? Don't you know this? Damage to categorical hemisphere leads to. Oh, what is this categorical hemisphere? You know, the brain hemispheres anatomically. Okay, I'll start from the very basic. The handedness concept. Handedness. So in the world, most of us, as we see, are right-handed. Some of us can be left-handed as well. Now, if you look at the statistics across the world, 93% people are right-handed and 7% people are left-handed. Right. Now, when I look for the speech areas, Wernicke's and Broca's, they are not on both the hemispheres equally. They are present on one side, they are functioning only on one side. Depending on that, we divide the hemispheres also. The left hemisphere and the right hemisphere. Now, as per Genong, if I read it, the left hemisphere is a dominant hemisphere and right is always considered to be non-dominant. Why do we call the left hemisphere as dominant hemisphere? Because this part of the brain is having the speech area which are functional. The right wala might also have it, but over there it's non-functional. Okay. Now this left dominant hemisphere is also known as categorical hemisphere. Categorical hemisphere. The right non-dominant is known as a representative hemisphere. Representative hemisphere. And the question lies in this knowledge that what is categorical hemisphere? It's a dominant hemisphere. If you have a damage over there, what kind of speech deficit are we going to have? Now look at the option. Normal speech is absolutely no. Increased speech jargon, decreased speech telegraphic, or a senseless fluent speech. Look at the options B and C. They sound more like a layman term. I am speaking more, does it mean I have aphasia? No. You're speaking less, does it mean you have got aphasia? Absolutely no. The answer for this lies in option D, the senseless fluent speech, in which the person is talking senselessly and over fluently sometimes. So I will mark the option D as the best possible and the appropriate answer. I agree with your thought that B and C are also correct. But since in this question they've not asked particularly about Wernicke's and Broca's, he's just asked me which aphasia fits into the best one. The senseless fluent speech is a jargon explosive speech that happened in a patient of Wernicke's. Just the word increased speech doesn't mean a kind of a jargon explosive speech. No, it has to be senseless fluent with neologism, right? Patient being evaluated for aphasia is unable to repeat sentences correctly and name objects properly. His repetition and naming is gone. However, the patient's speech is effortless. He is able to speak on his own. There are frequent errors in word choice and obvious difficulty in comprehension. So my patient has got difficulty in comprehension. He is unable to repeat and unable to name the objects properly. However, this patient's speech is effortless. Look at all these possibilities. Wernicke's is gone. His comprehension is gone. His naming is gone. Repetition is gone. While his Broca's is intact, that's why he's able to speak effortlessly. Okay. So this is the damage in the Wernicke's area, that's for sure. On which side? Left, the dominant hemisphere. And where is the Wernicke's area located? Temporal lobe. As per Genong, if I look carefully, and in anatomy books as well, they try to explain that these areas are more or less located at the overlap junctions. Like the Wernicke's is in the superior temporal gyrus over here. The Broca's is in the inferior frontal gyrus over here. But when they try to explain them in physiology book, they explain like this, that the Broca's is not only in the frontal. It's not only in the frontal. I'll just make it above. It's not only in the frontal. It's slightly frontotemporal. And Wernicke's is not only in the temporal, it's temporoparietal. But for our convenience, we should know that the Broca's is more in frontal and Wernicke's is more into temporal, so that we remember it better. Look at this option now. A is the best possible answer. If it is a case of Wernicke's area, the damage is to be there in the posterior temporal and the parietal lobe on the left or the dominant hemisphere. Easy, clear answer. Chalo, let's read this question now. 75-year-old male with an acute stroke on examination is about a mild right arm and the face weakness. He has a spontaneous speech with occasional paraphasic errors. That somewhere reflects your naming problem, right? So in my patient, the naming, the repetition, the fluency and comprehension I need to see. He has got a spontaneous speech. His fluency is intact. Correct. With an occasional paraphasic errors. That means naming is not gone, it's impaired. He can understand and follow the commands. Comprehension is intact. And his repetition is severely gone. Easy, clear answer. Tell me. Very simple, very clear. Tell me the correct answer option. Comprehension intact, fluency normal. Naming impaired, repetition gone. आपका क्या नाम? भूपेंद्र जोगी. कहाँ से आए? भूपेंद्र जोगी. Don't forget भूपेंद्र जोगी, the Man of the Year award. Okay. Right. Thank you. Patient with aphasia has an impaired comprehension for spoken words. He has got impaired comprehension for spoken words. He has impaired repetition. While his naming is preserved and fluency is intact. So where is the damage likely? And I'll give this an order also A, B and C. Batao. Look at this and tell me the answer now. First of all, what aphasia are we seeing this as? Impaired comprehension for spoken words, impaired repetition, preserved naming and fluent speech. The patient isn't deaf, but he is deaf to words. Pure word deafness. Correct. And then finally, the answer is A. The damage is over here. Okay. Simple. Oh my God. Such a big question. Let's try to find the answer. 62-year-old female presents with stroke evaluation due to acute right hemiparesis for the last several hours. On examination, she has got a right facial drop, right arm weak. See, every time a phasic patient will have right weakness because the damage is on the left dominant. She is having noted to have an effortful, fragmented speech. Kiran is unable to name several objects. Her comprehension is intact and has got a difficulty in repetition. It's a classical finding of what? Broca's aphasia, fragmented, telegraphic, broken speech. Now, which artery supplies Broca's and which artery supplies Wernicke's? A quick recap on this. If you know the artery, the parent artery, middle cerebral, it seems to have two divisions with it, no? Superior division and inferior division. Please remember the superior division of the MCA supplies the Broca's area. The inferior division of the MCA supplies the Wernicke's area. So this has to be a damage in the superior division of the middle cerebral artery. Correct? Right. D. Patient is having impaired comprehension only for reading, but normal comprehension for spoken language. The repetition of spoken words and fluency are normal. Like I pick up the mobile phone when it starts ringing. I know this is a mobile phone, but first of all, I'll always look on the screen who is calling me. I just keep on looking at the screen and just wonder who is calling me. Kaun hai ye? So I cannot read what is written. Is pure word blindness. It's nothing but your pure alexia. Read this question again. Don't be blind to these words. See, when you have pure word deafness in the class, in the exam you'll have pure word blindness. Okay. Someone wanted this to be repeated. Transcortical aphasias. I'll repeat this for you. Now we have got transcortical aphasias in which the damage lies in the association area, sensory or motor. Now, if I locate these areas, where are they located? Again, a small diagram. This is the Broca's, this is the Sylvian fissure, and this is the Wernicke's. Quite near to them over here are your association areas sitting. This is the motor speech association area, and this is the sensory speech association area, connected to your Wernicke's and Broca's respectively. Their main aim is to help you for comprehension, fluency, and naming, except for one variable, that is repetition. Repetition has to be perfectly intact. Now, if you have a damage in the motor speech association area in this side, and you have a damage over here, anatomically speaking, what should it be known as? This is anterior and this is posterior. Simple name, anterior and posterior. So what happens now? If I look at the variables, comprehension, naming, repetition, and fluency. Let me find out the first thing which is normal in both the transcortical aphasias, repetition. Now, anterior transcortical should behave like Broca's and posterior transcortical should behave like Wernicke's. So, the posterior transcortical is Wernicke's, like comprehension is gone, naming is gone, fluency might remain normal. If the anterior transcortical behaves like Broca's with an preserved repetition, then fluency is decreased, naming is gone, and comprehension is intact. And what about this isolation aphasia? That's another name for your mixed transcortical aphasia, the echolalia concept. He's living alone, isolated. For him, the repetition is normal, rest all is gone. Got it? So look at all the transcortical aphasias. A very simple trick to remember them is that they have got a preserved repetition. Anterior transcortical, sensory transcortical, motor transcortical behaves like Broca's. Posterior transcortical, sensory transcortical behaves like Wernicke's with preserved repetition. And mixed transcortical, living alone isolated, is this with preserved intact repetition. An extra point again to add to this, what artery will be causing this? Arterial infarction. If I look at this part, this is supplied by ACA. If I look at this part is supplied by PCA. So an ACA infarct is going to cause motor transcortical or anterior transcortical aphasia, while PCA infarct will cause a sensory or a posterior transcortical aphasia. Chalo, tell me the answer. Impaired comprehension, impaired naming, but normal fluency and normal repetition is posterior transcortical, also known as your sensory transcortical aphasia due to PCA infarction. Okay, right? Oh my goodness. This was a patient which I saw in the hospital once, In the live classroom, I keep on telling about this patient. This patient came in the hospital emergency with an acute chest pain. And now what happened? We resuscitated him, he recovered. After 3 days, I went to his ICU. He was awake, alert, extubated. His speech was limited to repetition of words and sounds produced by those around him. He had no apparent comprehension of language and produces few sounds spontaneously. You know what happened? I went to his cubicle. I wished him good morning. He answered me good morning. I asked him, how are you? He answered me, how are you? No one ever asked me in the morning, how are you? I said, I am fine. He said, I am fine. Then suddenly boss came on round and he asked me, where is the ECG? Patient asked me, where is the ECG? I said, I lost it, sir. Patient said, I lost it, sir. First of all, I thought, why is voice echoing so much? Some Ekta Kapoor ka serial going on here. No, kya? Or Sasral Sin ka, maybe. Anyway, so this was something which was constantly done by him, repetition. He never understood the whole scenario, what's happening around him. Whatever we spoke to him, he repeated the same thing back. No worries, no worries. So this is a classical example of echolalia. Constant repetition, kata laga, uima. Which type of aphasia is likely suffering with? Mixed transcortical or isolation aphasia. Correct. An elderly male suffers a stroke which appears to involve the left internal capsule rather than the cerebral cortex. This results in paralysis of his right arm and the leg. Tongue deviation to the right side is lost and speech is slurred, fluent, grammatically correct. What is the speech deficit we are suffering with? Look at this. This is the brain, the cortex that you have. This is the Broca's area where the word formation happens. This is the Wernicke's area where you have understanding. Between the two, you have the arcuate fibers to connect them. But when you form the word, you speak it out by the tongue. Your tongue is always under the control of a cranial nerve whose number is 12th. And now this 12th cranial nerve is somewhere having a nucleus located in medulla. The Broca's area, the word forming zone, is connected to medulla, the 12th cranial nerve nucleus, through a tract known as corticobulbar tract. Corticobulbar tract. So now we have a damage in the cortex above. This is known as aphasia. While you have a damage in the corticobulbar tract or the medulla, you name this as dysarthria. Correct. If at all you have a damage or a problem in the laryngeal vocal cords, then you'll name this as dysphonia. So we have speech deficits, speech disorders, which are classified as a cortical disorders, aphasia, subcortical lying in the corticobulbar tract, or medulla like brainstem syndrome, dysarthria, and finally the vocal cord palsy, the dysphonia. Three disorders. So look at the language again. The speech is slurred, fluent, grammatically correct. His tongue movement to one side is lost. Got it? So now what happens this time? He has got slurring of speech. Whenever he wants to talk, his speech will be very often slurred. This is known as dysarthria. There's another speech pattern that you all should know about. That is known as scanning speech. Where is it seen? Cerebellar lesions. Just to compare it with the alcoholism, if you see an alcoholic walking, he's walking with a drunken broad-based gait. And people after drinking alcohol possibly and probably talk in a language which they're very poor in, English. So one friend will call the another friend on phone. I'll call him here. Hello brother, how are you? Please send me some money. He'll cut his phone immediately. Because he's reading every word in his mind. He's scanning every word. A typical scanning speech pattern seen in a cerebellar speech deficit. Okay. Okay. So that's all. That's all for the day. Any doubts, any queries, do let me know. So happy Valentine's Day and Saraswati Puja to all of you. चतुर्लांगलिंगम अगेन सिंगल हूँ बोलते सब है, होता कोई नहीं. Okay. चलो, any doubts, any queries, do let me know. I've done with aphasia. Maybe this kind of a different teaching I've adopted this time, the trilogy or the triad system. Easy to remember, recollect, revise everything. Okay. So keep on reading, keep on studying, and keep on attending all these lectures. Medskool will be completing one chapter every time if you see. And try to solve MCQs and stay connected. Okay. Chalo. Bye, bye, bye.